So I run my trauma arrest very different than I run my medical arrest if I know that it's a trauma. A degree of major thoracic injury or abdominal injury. These are patients that we would often open up for a thoracotomy if they're within a short kind of time window of having arrested. But for getting access to doing those interventions, I don't want anyone doing chest compressions because that's going to slow me down. I need full exposure. I need to get a scalpel. I need to get into the chest and open the cavity, and I can't do that with someone beating on the chest.
Let's say they do go into cardiac arrest. What do you think about the quote, "No one comes back from trauma"?
Yeah, I think it depends on the location, and it depends on what they arrest from, right? We've had trauma and the other thing is, sometimes it's hard to tell whether it was really a trauma or a medical arrest, or someone may not be there to provide the story. So I run my trauma arrest very different than I run my medical arrest if I know that it's a trauma. For me, here's when I prioritize interventions and access over chest compressions. So, in the in-hospital environment, again, someone comes in, traumatic cardiac arrest, let's say there's, we're suspicious for some degree of major thoracic injury or abdominal injury. These are patients that we would often open up for a thoracotomy if they're within a short kind of time window of having arrested. But for getting access to doing those interventions, I don't want anyone doing chest compressions because that's going to slow me down. I need full exposure. I need to get a scalpel. I need to get into the chest and open the cavity, and I can't do that with someone beating on the chest. So for me, I just, as soon as these patients come in, often CPR is going in, I hold CPR immediately and get them over onto our stretcher so we can get access to that. And for me, I think traumatic cardiac arrest, what are the reversible things that someone dies from that can be addressed? For me, it's tension pneumothorax. So here you'd be doing needles on both sides of the chest. For me in the in-hospital, I'll usually do like a finger decompression on both sides. You can follow that with chest tube afterwards. Again, if I think there's some degree of concern for possible tamponade physiology, or maybe we want to go and try to cross-clamp the aorta to reduce the blood loss for like a catastrophic abdominal injury, for example, to get some volume in them, then we might proceed with doing a thoracotomy in a select number of these cases as well. But those are usually the things that we do. But as a whole, and this would be supported by the literature, traumatic cardiac arrest in the field, there's not a lot that's going to be easily reversible, other than needling someone, or if it was an airway thing, then just opening the airway and getting some ventilations in them.
That's exactly what I was thinking. Chest needles, good airway management, pelvic binders, stop any bleeds. But would you give blood for somebody in a traumatic cardiac arrest?
Yeah, for me, it's all about time, right? So, if it is fresh in the, fresh trauma in the field, we arrive within 5-10 minutes, and we think that it's maybe something like workable. I don't know if that makes sense. I think absolutely. Then we would give a unit or two that we have. Ornge, we've got 2 units of red blood cells as kind of our standard blood on board cooler outside of the SWIFT study. So I think giving a unit or two, at least to address that hypovolemia that you have. On the in-hospital side of things, for me, a lot of it is time. So, there's a couple of different guidelines for doing a thoracotomy, if you'd say, and really key things that usually would factor into whether or not we're going to be opening someone's chest if they had any signs of life. So even if it was like a PEA, right? Because if they had like a rapid tachycardia, but we could detect a pulse, this is probably someone that did have some degree of perfusion. They're just so shut down, we can't get a blood pressure, we can't feel a pulse. But for me, if they have PEA, they're in the field or recently, or at some sort of signs of life, they're moving, they're moaning, something like that. And then there's a bit of a time component. So has it been 15 minutes is kind of the general rule that we think of, that a lot of us would go by. If they've been down for 15 minutes or less, then we'll usually proceed with then trying to do some volume resuscitation, decompressing the chest, maybe opening up for doing a thoracotomy if that's the case. Once you get outside of that 15-minute window, we don't tend to see a lot of survivors on the side of things. And there's always risk with any sort of intervention, right? So you think about a thoracotomy, for example, there's a substantial risk to the providers often. It's a really, sharps, needle stick injuries, those happen in like 5 or 10% of cases. So you have to kind of balance that risk for, do we think this is going to be someone who might have a meaningful outcome versus what are the risks to providers, or just doing something that, is unlikely to have any benefit. It obviously can be, quite a traumatic intervention, if you will.
I find it fascinating. I know the listeners will too, to see the actual architecture of like how you operate on these calls. Every detail matters, and I'm tailoring what I'm doing to the patient, the findings, and the risk benefits to everyone. Because all those little details matter, which is very interesting. And correct me if I'm wrong, I was reading systematic reviews for this. Like, it's the mortality rate for traumatic cardiac arrest in the pre-hospital setting could be in the 90s, depending on the system. But if you have a physician on scene in your system, of course, the mortality rate's a little lower. And I would love to hear your thoughts on that, because you're able to look at all this and provide maybe more extensive treatment for them.
Yeah, and this is where I think it's always important to, we talked about this earlier, it's always important to try to look at the context of those other studies and what those systems look like, right? A lot of the European model for pre-hospital care is very physician-medic driven, right? And that's kind of the mainstay for France, Germany, UK. There's a lot of those models where, what we might consider critical care would be physician-medic model there. And within Canada, I would say, our critical care paramedics have such an expanded scope. There's probably less benefit for some of the physician interventions that might be able to be done. So, and I say that because of, in a lot of those studies that were included in that review, things like rapid sequence intubation, for example, are considered really a physician-only skill set that, again, our critical care paramedics that we have within Ornge and across Canada do have access to that. Same with blood administration and things like that. So, do I think that there is that? Certainly, there are meaningful interventions that having a critical care response, right? And this could be paramedic, it could be a physician, would add to, that would increase your likelihood of managing a major trauma patient. And for me, it comes down to bleeding, right? I think that's kind of one of the things that they have access to blood products. The efficacy for doing things like chest decompression. So we know that needles are okay, and I'm happy that everyone's hopefully going towards kind of the Turco needles. But your general 14 gauge angiocath only makes it into the thoracic cavity like 60% of the time on some autopsy studies. Our patient population tends to be getting larger, which makes the success of those needles even less. And then, of course, if it's a massive hemothorax, it's not going to do anything anyways. So, there's something about just being able to stick a finger in the chest cavity to decompress a little bit more and have an idea. Obviously in some more advanced air ambulance services that are doing bedside or roadside thoracotomy, roadside REBOA. Yes, there's definitely going to be a select patient population from that will benefit. But I'm always cautious of exploring that within our system, because again, they're just so different. And a lot of those systems too, because there's a physician there, they kind of bring almost like the trauma bay to the patient. I think that's the key concept, right? So again, what are the meaningful interventions that need to be done at the roadside to bridge them to getting to access? And for me, that's blood, that's being able to stop bleeding or through things like REBOA or thoracotomy or chest tubes for some of that stuff. And then an expanded drug selection for, again, we talked about earlier, things like different medications for your rapid sequence intubation, maybe even vasopressors, that type of stuff.
Well, that goes back to how the SWIFT trial's addressing this inequity at this time, that we're getting blood in the pre-hospital setting now. And land ambulances can do chest needles, and a lot of them have the 12 gauge needles, which isn't still optimal. It's better than the 14 gauge of failure rate, but that helps. And we got a better sight, the fourth anterior axillary spot. So it's interesting to see where trauma care is going in Canada. And even though, like you said, the systems are totally different elsewhere in the world, we still need our own studies to prove what are our stats here.
Totally. Yeah. Right. We don't have too much that's looked at. There was the old Opal study that looked at cardiac arrest and trauma, but the implementation of your ACP medics across the system, and the benefit of that for cardiac arrest was proven, and it's helped support that. It was interesting in trauma that we didn't really see the same outcome. If anything, they might have trended to those having worse outcomes if treated by an ACP. And I don't think it has to do with the skill set. I think it just has to do with just some of the limitations of some of the skills, I guess. So there's always this, like, if you're able to, sorry, I shouldn't say with the skills, it's with the interventions that are a benefit to those patients. And I think a lot of it is things like access to blood and that time for definitive care, and then augmenting with that challenge with balancing airway, protection, and the consequences of intubating patients, that when you don't have access to blood and pressors, how challenging that can be.
I know you get this question probably a bunch, but this is good just for land ambulance to, when they do calls of Ornge, do you need an 18 gauge to infuse blood?
No, not at all.
Yeah, the classic adage. It's like, you can see the anxiety. It's like, I know this patient needs blood. I can only fit a 24 on this patient. Are they going to yell at me? Will they not be able to get the thing they need if I put in a 20, 22, 24? So no, you can infuse blood through mostly everything, right?
Yeah. It's even just like, even if we don't end up using that line for blood, it's still helpful to have multiple lines for these patients, right? Like usually your one line is going to be used up for blood. You can't use that for drugs or anything. So then having something else that you can give, pain medication, give your TXA, those are the other things. So yeah, access is always a challenge and always important. So I'll take anything over nothing, right? Like, yeah.
I always remember the quote, not mine. A lot better person said it. It's an 8 or 22 in the hand's better than 18 in the sharps container.
Yeah, exactly right. Yeah.
Take anything. Yeah. How else can we facilitate to make sure, like even if land ambulance paramedics can't get blood, how can we ensure a good patient handover and optimize trauma care? So when you arrive and when your colleagues from Ornge arrive, we can have that good standardization and handover.
Yeah, from a arrival at a trauma center perspective, at least kind of the St. Mike's and Sunnybrook and SickKids experiences, we've been shifting more towards a standardized sign over to the trauma team using the IMIST AMBO approach. I don't think that's any better than other approaches necessarily, but I think having some degree of a structured handover is important. I think the one thing where the system works well for patients is that early recognition that the patient needs to go to a trauma center. And sometimes that's just done with, 911 caller information that gets relayed to the CAC and we launch Ornge. But it's trying to help facilitate that whole kind of rendezvous piece if you're assuming you're not going directly to a lead trauma hospital, right? So if you're transporting a sick patient, and Ornge has been activated, obviously keeping us on is ideal. We'll continue on for a modified scene call if we're not able to land on the scene at time, but keep us coming. We'll find our way to the closest hospital if you're not able to rendezvous at another pace or another spot along the way. But I think that's one of the key things. And there's work being done right now at a provincial level for trying to revise the field trauma care standard. And I can't really get into some of the details for that today, but hopefully we'll see improvements in how we identify sick patients and how we can help improve some of that rendezvous and coordination for getting them to the site that they need as quickly as they can. For some of that. So, hopefully you can have me on another time once that's kind of ready to go. We can chat all about field trauma triage. My second favorite thing to talk about besides blood.
You're always welcome back. And I was looking at this. Correct me if I'm wrong. You did a review where you have vital signs, whether it's heart rate, blood pressure, SATs. if they were omitted from the paperwork, there's a signal that the patients did worse.
Yeah, a lot of studies that look at developing scores or prediction tools for bleeding patients or for trauma, for example, you use something called a trauma registry. So in Ontario, any patient that's admitted to any of the trauma centers, it's a trauma team activation. It's a whole bunch of data collected on those patients, and that's usually what a lot of people use for then developing these scores, because you have like thousands of patients, which is what you want if you're trying to develop a score for things. And so we looked at some work, and what we found was, there's a lot of missingness within that data set. This is also the challenges with doing research, right? You obviously have pre-hospital records and your ACRs, and those don't always make it to the in-hospital records. The data gets missed or not correctly linked. And what we found is patients that have their data missing were more likely to have died or other things. And I think it probably speaks to the difficulty in connecting those records in the pre-hospital, the pre-hospital data. Often these are, John or Jane Doe patients. We don't have, a name. We don't have an OHIP number or anything to link their data afterwards. So it seems like that data is missing more on those patients. It's just something to keep in mind when you're trying to apply different scoring systems to our patients. So I think of shock index, for example. I think it's one that is taught really well, and I think is really useful as a concept, right? But if you look at how well shock index actually predicts patients that are massively bleeding, then it's quite varied, not surprisingly. But often when you develop a score that has an outcome of your interest that's missing quite a bit, or missing in a way that's quite biased, then how well that score performs in real life is not as good as that first paper that comes out. And I think that's kind of something that we're seeing a little bit with shock index, for example.
Amazing. And last question, because I got to let you go. With all your research, your bedside applications, all of the initiatives you're doing, it's evident you truly want to help the system change to impact the most patients in the most positive way possible. What's the benchmark that you say, I'm happy in my career that I've impacted the system? Like, what would be the benchmark for that for you?
Oh man, I think there's gonna be one. This like the I think for me, there's kind of two things I'm hoping to kind of leave within this. One is, within Ontario, we're starting to go for what was considered an exclusive trauma system, which meant either you're a trauma center or you're not a trauma center, into what's considered an inclusive trauma center or trauma system. Sorry. And this is where you have like your lead trauma hospitals, your level 1 trauma hospitals, when you have these level 3 trauma centers, and maybe one day a level 2 trauma center. But these other things that maybe aren't like the big full trauma center, but can provide a bunch of stabilization within that. And my one hope is really through the work that I've done and will continue to do is, how best can we use and improve our pre-hospital trauma system to try to get that it applies within that system. So getting sick patients to where they need to go, and maybe not as sick patients closer to home or they're closer to family. And we're not, using all of the big resources all of the time, and how best we can optimize that. So that's my one, is kind of a provincial field trauma triage in the trauma system. And if I can implement some changes on that would be great. And the second one for me, I think, is really improving access to blood within the pre-hospital Ontario space. And yes, we're not going to be at a point, unless we have like a insane change in the number of people donating blood, that we're going to have blood on every land ambulance. But I do think that there's other products coming down the road. Again, like a freeze-dried plasma product. Now, these things are good for 18 months, right? That is something that I do think would be beneficial for our system with the transfer times that we have. And that, I think, is something that could be feasible for stocking on some land-based services. Again, this is kind of down the road, but those would be things I'd like to see. Better pre-hospital trauma triage, making sure that the system works to identify the sicker patients, and the sick patients to make sure they get to the definitive care they need to as timely as we can. And then the second thing is improving access to blood and blood products for bleeding patients, to really act as that bridge to get them to the definitive care that they need.
Well, I commend you once again for all the work you're doing, because you're trying to implement those changes. with everything you're doing. And I really appreciate you coming on and being able to describe this information in a very digestible way. And you're very down to earth, very approachable. And I know everyone will love this. So come on anytime. I had tremendous amount of fun. This podcast is for educational and informational purposes only. It does not provide medical advice, diagnosis, or treatment. Always follow your local medical directives, protocols, and scope of practice. Consult appropriate medical authorities or supervisors for clinical decisions making in real-world situations. This podcast does not reflect any of our employers.